Thank you, Jenny. And firstly, I would like to pay my respects to elders past and present. Today, I want to expose to all of you what I think is a really dirty little secret in medicine. And I want to start a conversation because, as Jenny says, this is one of those topics that's just not taught, not discussed, and it really does have a practical effect. Those senior doctors like myself, like James, others in the room, we're all well-meaning generally. We care about our patients, we care about our trainees, we care about those people that we work with. But as a rule, those senior doctors, the guys that you call the bosses, on a good day, they're probably a sub-average manager. And on a bad day, far worse than that. And in certain situations, there are those amongst us who are really abysmal at managing and leading within the health environment. And the problem with having so many sub-average managers as a rule is that we, the general bosses, are very bad at dealing with those that are the very bottom rung of management. So it leads to problems like this. This is just one of many dozens of comments that came from the New South Wales JMO census about issues around bullying and harassment. And if you read through the literature, you'll find this everywhere. Now, I'm pretty sure this boss that this trainee went to talk to cared about the trainee and wanted to do the right thing. But look at the impact of that response. And that's a management response. I'm coming with a complaint and an issue. I want you to deal with it as a manager. So if we look at some of the quantitative data from that survey, almost 60% of JMOs were reporting on that census that they'd experienced bullying. Almost 20% had experienced sexual harassment in that year. Yet, 40% of all of those chose to not even do anything about that behaviour in the environment. And for the 60% that did, most of them reported negative outcomes from escalating. So that's a real problem, I think, and I think that's a problem about management as much as anything else in terms of the bullying and toxic culture in medicine that we're so worried about these days. So why do we have this problem? Well, today I'd like to have a conversation with you and talk about a few things, some of my thoughts about why we've got this situation. So what I'd like to do is give you a few reasons why I think management is such a stretch for doctors in medicine. Then I'd like to talk to you about the issue of empathy, because I think empathy is the key for trainees understanding why they might be having difficulties with their bosses. And it's not I'm not talking about just bad bosses out there, I'm talking about a variety of difficult boss behaviours that you might encounter. And I'll give you some examples and I'm sure you'll recognise some of them. So then I want to give you some practical tips about how you might deal with those difficult boss situations. And I'm going to talk about difficult bosses, and then I'm going to talk about a subset of difficult bosses, and those are the bully bosses. And there is a different approach, I think, to dealing with a bully boss. You do have to tread very carefully with those situations. And finally, because there are some senior doctors here amongst us, and all of you at some point will become, hopefully, a boss in medicine, you're thinking, well, this is very good, Anthony, you're worried about the quality of management in medicine. How can I avoid becoming known as a difficult boss? So I'll try and tackle that as well. So, who here has had the opportunity to work for a really great boss in medicine? Yeah? Well, I'm not going to ask you for your example, James. Would anyone like to talk about their great boss? Someone want to share? You don't have to reveal names or anything. I just want to know a little bit about what you thought made that person such a great boss. What did they do differently to others? Thank you. Your name? Natalia, yeah.
So this was just someone who was running the ALS calls. So he wasn't really my boss.
So somebody running a course in ALS?
Running ALS calls.
Yeah.
And but I just noticed that everybody he dealt with, he asked them to do things. When they did them, he would say, "That's great. Thank you, whatever your name is." And he just took that moment. He was really smart.
Yeah.
But he took a moment to just look the person in the eye and say, "Thank you." It was excellent.
Brilliant, thank you. Well, thank you. That's an excellent example of something that's often not done that is core to the art and the practice of management, thanking people for their efforts. How often do you get told that you've done a bad job in medicine? Lots. How often do you actually get thanked for doing your job? Now, we all know the rule of fives. Has everyone heard of the rule of fives? Okay, so for every negative feedback you get, you need about 5 pieces of positive feedback to avoid becoming depressed and de-energised about your job. Negative feedback overwhelms positive feedback in terms of your confidence. So it's important that we actually thank people. And so this is one of the things that is not taught to us as doctors, as managers. And we don't get feedback on whether we're doing that enough. So who has worked for a difficult boss? Does anyone sort of want to share an example of a difficult boss that they've worked for? No one? Yes, up at the back. Yes, your name? Otter. Otter? Honor.
Like, it's an honour to meet you.
Oh, yeah. And you too. Thank you, Honor. What happened with your boss? Just talk and I'll repeat.
Okay, sure. So, I had a boss who was very particular on a certain structure to do things, and if you deviated at all, like the world would end.
Yep.
And that was just about it. So, like, constantly, even if you made a typo, it would be like, you spelled that word incorrectly.
Yep.
I'm aware that I spelled the word incorrectly, but you were actually asking me to dictate what you were speaking, like what you were saying, like 50 words a minute, but that's actually not very much. But, like, you know, just very, very quickly, and I'm trying to do the best I can.
Yeah. So there are certainly examples of those sorts of difficult bosses in medicine. I call that the micromanager boss, or you might call it the rules-focused boss. And I bet behind that particular boss, there's some sort of concern, anxiety about mistakes occurring. Possibly they've had a series of errors occur in the past, maybe around letters, for example, and so they become obsessional about getting them right because they don't want that to happen to them again. You don't know that. They don't share that information with you, do you? So you just see frustrations like, why is this person wanting me to edit this letter 10 times? I need to get to that family interview, for God's sake. So you can see how trying to understand and get in the head of the difficult boss can be helpful. All right, so my last question for you guys, I'm not going to ask for examples, but who has worked for a bully boss or an arsehole boss in the past? All right, quite a few of you. How do you know that they're an arsehole boss? Or let me reframe that question. Who's ever been an arsehole at work before? Oh, come on. None of you? None of you have been a jerk to someone else? All right, well, I have, and I regret it, but most of us do it occasionally, and people like James will pull me up and say, hey, Anthony, you're giving that person a tough time. You're being a bit of a jerk. Something going on there? And I go, yeah, sorry, I was having a bad day. Got a phone call from home. Apologies, I'll come back to the normal behaviour. Well, the arsehole bosses are very consistent. That's one of the ways you can identify them. So we all have bad days in medicine, and we're allowed to do that, but we're not allowed to keep doing that, and we should be open to others pointing it out to us. As I say, a key to getting inside the head of the difficulties you may be having with your boss, the key to owning it is to empathise. You don't have to agree with what they're doing, but think about it from their perspective. And one little secret there, I think, is to understand about how to empathise with a boss. Something that might be helpful for you as a general tip is to think about this. Your boss has got their own boss, okay? And that boss is probably driving a lot of the behaviour of the boss that you're seeing, which may explain why some of the things that you see from your boss are either annoying, or perhaps some of the things they're not doing are annoying to you. Some studies show, we're looking at middle managers, that up to 75% of the stress of a middle manager derives from their relationship with their superior boss. Okay? So you're going to become a boss one day, you're going to have other bosses and other KPIs and imperatives on you. So have a bit of empathy for that particular situation. So why do we have this problem? Well, I'm going to give you 6 reasons. The first reason is, actually, if you look at it, good management is a problem everywhere. And that's a little bit reassuring, isn't it? Because, we're pretty smart, we got into medical school, we know a lot of stuff, we like reading, we like learning, we like developing. Management's actually hard, and companies that understand that are successful. Companies like Google talent manage management. They make sure they hold on to the good managers. They make sure they support good practice in management. So that's one thing to know. If we look at health, health is hard to manage. Look at this. From the last New South Wales Health or New South Wales Public Sector Employee Survey, only 45% of people who responded to that survey had a favourable view of senior management, i.e. more than half of the people in health that responded to that survey didn't think managers were doing a good job. If you look at other surveys, just more globally, an internet survey recently showed that 34% of employees would not work for their current boss again, given another chance. So health has this problem with management. Part of it comes down to this concept called the Peter Principle. Has anyone heard of the Peter Principle? No? So it's a psychological principle. Essentially goes this way. People in an organisation tend to be promoted and rewarded on their past and current performance, which is great if you're just going up the scales in a technical sector, like you're being a clinician or you're doing a service sort of thing. But think about this. At some point, you kind of jump from just doing clinical work to also managing and leading a team. So if I'm promoting you just because you're a great clinician to the next management role, I've done nothing to support your development as a manager, that's a real problem. And that's what happens in health. We don't prepare people for the step up to management. So if we look at nurses, allied health, everyone who's clinical in medicine, very rarely do we actually support their development as a manager until they actually have to take on that sort of role. Thirdly, we need feedback about our performance as managers, and we just don't ask for it. How often has your boss asked you, is there something they could do to help you do your job better? I bet rarely, okay? That's the sort of feedback you need as a manager. You need to be open to criticism of your performance and supporting other people in your team. Now you can do that by being open and setting up a psychological safe space with your trainee. You can do it other ways, like doing a 360 evaluation. Fourthly, we just don't teach doctors how to manage. Yeah, I know it's in CanMeds and it's probably on some curriculum document there somewhere, but after we get through the medical expert role, which is probably most of it, then we get into the communicator and the collaborator and some professionalism and leadership. Do we really ever get to the art of management in our training in either undergraduate and postgraduate medicine? Maybe RACMA aside. No. Fifthly, this is where I have to stop myself from ranting, but I do firmly believe that leadership is not the same as management. And if you look at the CanMeds framework, they've changed the manager role to a leader role. And that's great. We need doctors who want to lead and inspire and change direction and innovate. But it's not the same as getting into the weeds and putting in the structures and processes to get things done. And finally, I think there's just a skills transfer failure here. Most of us, or most senior doctors that you know, will probably be very good supervisors, maybe great mentors, great problem solvers, a lot of great networkers, and can use that network to get things done. But we don't, and these are all skills that can be used to be an effective manager. We just don't recognise it, and we don't find ways of transferring them over to being a better boss. So let's talk about a few types of difficult bosses that you might encounter in the environment, and I'm hoping you might recognise some of these. Firstly, the yes boss. Now the yes boss can be initially quite inviting because let's imagine this, you're about to do your next rotation, you've spoken to your new consultant, you thought, oh, I might just ask if I can have a long weekend off to go to my best friend's wedding, and you're kind of expecting that normal, oh really, do we have to, that's going to be difficult, but you get this immediate email back saying, yes, that'll be perfectly fine, thank you, see you on Monday, and you go, wow, I'm going to enjoy working for this person. So you turn up, and you find out that this consultant says yes to anyone and everything, any staff, any patients, because they just seemingly don't want to upset anybody. And that leaves you a bit frustrated after the first week because a lot of those yeses as a trainee mean you have to do extra things, like extra consults, extra family interviews, booking in of another patient to an already busy clinic and running the wrath of the receptionist. Lots of things that frustrate you. So, I like to rate these difficult bosses. On a scale of 7 out of 10, I'd see that as fairly frustrating. Is it going to harm you as a trainee or patient or patients? Probably not. You're going to do extra work, but you're going to get the support from the yes boss probably. And the key thing is this person going to be up for a chat? And I would suggest fairly high likelihood. So, how do we understand and own this problem? Well, I'd suggest to you that this yes boss maybe very new to their role. They might be a senior doctor from somewhere else, but new to the hospital, but more likely just a junior consultant getting out and getting started. And think about it, if you're a junior consultant who just moved up in the pecking order to the new ranks, you've got a whole lot of senior consultants around you, and you don't want to rock the boat, you don't want to upset them. And the best way to upset other people is to start off on the no foot. So you're obliging. So they are worried about their own credibility. So how can we work with that? Well, as I said, I suggest to you that these sort of difficult bosses may be open to one of those quiet chats in the tea room or something like that. And you can be empathic and sort of talk to them about how they're feeling about their transition and sort of relate to that a little bit. Maybe you can suggest to them that you can get their back by being happy to take on the no role a little bit more. And they will probably be happy for you to do that. But you need to also make clear to them what you need to get your job done and what you need from them as a boss. And that might inspire them to focus a little bit more on you and less on their colleagues. The next difficult boss that I would like to talk about is the absent boss. Who's had an absent boss here? Yep. I'm guilty of this at times. I would have to put myself in this stereotype occasionally. So the absent boss is probably well known in the hospital. They've got an established reputation for just not being there. They always seem to be away at a conference or an important management meeting or something like that. So I put them as a 5 out of 10 in terms of frustration because you're actually not around them very much, so it's hard for them to be that frustrating. Probably more harmful because you need them to back up your decisions, and if they're not there, that's a problem. Are they up for a chat? Well, I'd suggest to you the main issue here is actually being able to track them down. So how can we get inside the head of the absent boss? Well, this sort of boss tends to collect a lot of roles and is in high demand for their expertise. And they often get a bit frustrated about the clinical work because they see it as a bit of an opportunity to get bogged down. And they're probably struggling to manage their time. So, is this your opportunity that you've been looking for to develop leadership skills yourself? Well, it probably is because there's a vacuum. So you can treat it that way. And I would suggest to you that the absent boss is unlikely to be annoyed if you take on more responsibility for them and cover things for them. Even if that comes to the point of saying, look, I'm not getting enough supervision, I need to get it from another person who's happy to give me that. These sort of bosses will be happy if you manage up. They may well be lured back if you can use some of your newly developed management skills to do things like streamlining an award round. If you can show to them you can get the award round done in an hour, they're going to go, yippee, I'm coming back, I'm booking some time for that, that's effective. So that's two types of difficult bosses. Am I hitting a nerve resonating there? You come across some of those? I can't cover all of them, and these are stereotypes, let's acknowledge that. There are probably multiple, but I think it's important to get to the ones that you're most concerned about. So what about bullies? Well, as I said, we need to tread carefully around bullies. These are situations where it might be a little bit more difficult as a trainee, particularly on your own, to step up and counter the behaviour. Now, one of the ways to think about bullies is to sort of think about the types of bullies that you might encounter in the environment. And if you look at the research, there are actually two main types. And this is the more common one. We call this the explosive bully boss. I have to give credit to Leonie Watterson for helping me discover this one. So the explosive bully boss is the more common bully in the workplace. They're often confused with the less common form of bully, the one that I call the arsehole boss, but you might think of this as the antisocial or psychopath. The things that differentiate them out is that they are still very committed to their role. They care about the hospital and the patients. It's just that they lack self-control and emotional intelligence, and they let that vent on other people. Frustratingly, they're often well regarded and maybe even tolerated by their seniors because of their commitment. As I said, the motivations differ, but unfortunately the impact is similar. So I'd rate that as pretty frustrating, pretty potential for harm, and difficult for a chat. These types of bosses don't normally manifest overnight. They evolve over time. They often burn out. It's not just them being a bully in the hospital environment often. There are often stresses and frustrations in other parts of their life. They often or may even feel that being tough on people is doing them a kindness. And what often happens here is it's avoided that people talk to them about their behaviour. So they more generally benefit from a peer-based approach. And they can change. I've seen people change. They change with some coaching. They change with a colleague or a senior pointing out that their behaviour needs to change. From a training perspective, you need to sort of try and highlight that to others that can help facilitate that change, and you need to think about your own survival skills in this situation. And we'll come to them. Finally, we have the arsehole boss. These guys and women engage in bullying for bullying's sake. They like to belittle those that have less power in the organisation. They like the fact that they can leave other people feeling oppressed, humiliated and de-energised. So as I say, we might refer to them as sociopaths. Now, sociopaths isn't in the DSM-5, but there are ways of checking for them. And actually you're asking yourself, how common is this? Well, in corporate settings, somewhere between 1% and 3%. And sorry to you surgeons out there, it's about 3% in the surgical profession. That seems to be the rich vein for arseholes. So they are reasonably common in the environment, and really what we need to do is identify them, avoid them and manage them out if possible. So, report if you can, avoid if you can, and I'll come back to this point, quit if you can't, because I think you need to know that quitting is actually an option. So, Bully Survival 101. Tips for surviving bullying. First question, is the problem that bad? Now, I'm going to be controversial here because a lot of the stuff you're hearing in the doctrine is, please come out and tell us about these issues. We want to know, we want to be aware, we want to do something about it. And that is important, and there are now avenues for anonymous reporting, etc. But I'd put it to you, there are sometimes some situations where you have to, when you weigh up the consequences of you doing something about the situation of bullying versus how much of an impact is it having on you, it may make sense to just sit with it and tolerate it and wait it out. So maybe you've got an explosive bully who only tends to explode every few weeks, and maybe it's not you every time, and maybe you're coming to the end of your term, so maybe you can just wait it out. I mean, after all, no one else in the hospital seems to be wanting to do anything about it themselves. But there are situations where you have to recognise that it's getting to you. If it's de-energising you, if it's invading your social life and your family life, if you don't have an outlet, if you're stuck with this person for quite a long time, that's when you have to move past thinking, I'll just live with it and move and wait for it to go away. Quitting is an option. Quitting works. Quitting can send a strong signal if done the right way. Now, when I talk about quitting, I'm not just saying drop your job the next day because you're just being bullied and sign up to the locum service, although that is an option. There are often options for quitting within your health service. So, you know, there may be an unfilled term somewhere else that people are like, you know, maybe it's a secondment and the administrator's sort of struggling to get someone to do it and someone dropped out of it. Well, why don't you volunteer and go to do that to get away from the bully? There might be some short-term jobs you can do in the hospital. So there are always options for quitting. You need to not get stuck in what's called the sunk cost fallacy. There's this issue where we emotionally invest our time and commitment into a thing, something that's dear to us, and it's often our careers. We put a lot of energy into it and we've put a lot in, so we don't want to take it out or take it away. And then we tend to override the logical thinking to say this is not okay because of that. So we start to make excuses for what's going on. So quitting can be an option. Please don't quit in a peak. Lots of studies have shown when people just quit abruptly, they burn bridges. And actually their behaviour comes across as just like the bully that they're quitting from. So you can establish a bad reputation with your health service. If you're thinking about quitting, talk it over with people, do it logically, do it calmly, maybe try and line up the next job first, then do it. Do not burn your bridges. Now you're saying to me, Anthony, probably I'm hoping, well, if I quit, that's great for me, but what about the poor next sucker that's got to deal with this bully? Yes, I acknowledge you're passing the problem along the line, but think about it. If you don't quit, you're still suffering. If you do quit, maybe it sends a signal to those in charge that there's something wrong with this bully. And you can use things like the exit interview to sort of flesh that out as well. Thirdly, being avoidant does actually work. So there was a study that showed that when people were being harassed or bullied in the workplace, if they literally moved their desk somewhere further away from the bully, They retargeted. So think about it. Where are you doing your ward work? Where's the bully, coming in contact with you at the moment? Is there an opportunity for you to go and do the discharge summaries in the library or somewhere else where out of sight, out of mind? Can you change your schedule to avoid times when that particular bully's around? There may be opportunities to just avoid them. Or you can hide in plain sight. I think this is a great strategy for trainees because usually you're with other trainees and you're all being exposed to this bully. We can make a compact and a contract amongst yourselves that you'll never let yourselves be alone with that person. You'll always team up so that the bullying behaviour gets observed and that you've got each other's back. Fifthly, if you are in the bystander role, don't be one. So I'm talking about initially about being the subject of bullying, but if you're sitting there observing, please don't act passively in these sort of situations. At least go and provide support to that person. Maybe do a hide in plain sight compact with them. Or if you're feeling you've got the skill, maybe even point out to the bully that they're doing bullying. So I did promise to finish by giving you a few tips about how you might avoid becoming known as a difficult boss in medicine. As I said, I'm a bit of a nerd about management. I love it. It is hard. And it's not something you can just read a quick book about or do a short course on and do well. But I think it's worth thinking about in terms of your own development. So the first thing I would suggest, and some of you I know who've done the Lead program have already done one of these before, is get yourself some feedback. Set up a psychological space with, if you're a registrar, with your intern or resident to get some feedback from them. But actually invest in a real 360 evaluation and get some genuine feedback on your performance as a leader. The first time I did my first 360, it blew my mind. There were things in that report that I was really deeply uncomfortable with, but it helped me to grow and see where my strengths and weaknesses as a leader and a manager lie. You can then pair that sort of feedback with a coach or a mentor. And there's a bit of a momentum now in medicine to look at coaching and mentoring as a way of improving performance for bosses. Coaches and mentors can really help you to harness those hidden skills you already have and make you a better performer in a leader and manager role, particularly if you pair that with a 360-degree sort of process. And these are both fairly easy and cheap things to do these days. And my third tip for avoiding becoming a difficult boss, I'm coming back to the bystander proposition. I would put it to you, you might be a senior boss who's got a few flaws as a manager and a leader. But if you're not afraid of tackling that difficult conversation with one of your colleagues who's just way out of line, if you're known as the person who will tackle the bystander issue in medicine, most trainees are going to develop a lot of respect for you as a boss and a leader and probably be happy to overlook some of those other little foibles that you might have as a boss. So thank you for listening to me. I would like to acknowledge that I got a lot of my inspiration from this talk from a guy called Robert Sutton who 10 years ago hit the New York Times bestseller list with his book, The No Arsehole Rule. He's a professor at Stanford University, psychology. He's worked with top 500 companies. He's worked with hospitals like the Cleveland Clinic, cleaning up their arsehole problems. Imagine that, the Cleveland Clinic. Everyone knows how great they are. They acknowledge they have an arsehole problem and need to deal with it. On the 10-year anniversary of his first book, which is talking more about how organisations can deal with this issue, he's now published the Arsehole Survival Guide, which is more of an individual survival guide. And so if you're wanting some more tips and strategies for dealing with bullies, but also I think you can get stuff out of this in terms of just difficult boss behaviour, you can certainly pick that up, and I think it's a decent read. So, thank you. I would like to continue this conversation. As I say, I think it's a dirty little secret in medicine. I don't think we're talking enough about it. I think it contributes a lot to why we've got problems with culture in medicine at the moment. So I've put a lot of my thoughts out on the World Wide Web. If you follow that link to bit.ly Bad Med Bosses, it'll take you to a little mini course that I've started developing around this. And you'll see some of the examples that I've put together. I'm developing some tips for dealing with difficult boss behaviour. I'd really like to hear some stories from people that have had problems with difficult bosses and good bosses. We want to shine a light on the good boss behaviour as well. So hoping to collect some stories and use that to develop the course and put some more tips and advice out on the internet and get this discussion happening throughout medicine. Thank you very much.